So mainly little bit of difference between the anterior segment and posterior segment. First you have to learn to visualize the posterior segment. So sometimes some of the hospitals when you go for exams they will not have your have all the instruments. So whenever you go for an exam, make sure you carry your own set of instruments. It can be a diaphragmoscope, it can be a lens, preset preset lenses, along with your indirect and 20D lens. So always try to buy your own set of instruments and carry it with you yourself. Sometimes even if they may keep an instrument, it may not be as good as what you use, and you may not be able to see the fundus properly. So always try to carry your own set of instruments so you feel comfortable and much more less tense and much more peaceful in using your own set of instruments, because already you are used to it. So a lot of times it's just a spotter or a small short case, and it's unlikely to be a long case if you're following the old format. And make sure that you get some amount of history also. Even if it's a spotter, always ask for a history. This is actually the real thing which happened during my DNB exams 25 years ago. So we had a case of a cherry red spot, and everybody was diagnosing a CRAO, but actually it was a case of a blunt trauma. So if you ask a history, then I specifically asked for a history to just to see what was the reason for the cherry red spot. And except me, everybody else got it wrong, saying it was CRAO. Even if it's a spotter, always get a short history, so it will help you to come to a diagnosis. And when you're asking questions also, and you just have a set of questions you can keep practicing during your MS or DNB course. Try to ask the same set of questions so you get used to it, and you are able to, without skipping the important history, you can ask it. If it's if a RD patient, you'll have to ask about all the 4Fs, because commonly that field of vision, failing vision, flashes and floaters. Sometimes when you go to the exam, ask what this patient had as a complaint. So make sure that you ask all the history, and the positive scotoma in central serous retinopathy, and if it's vitreous hemorrhage, ask for previous episodes. So when it's a recurrent disease or a one-time disease. And also in ARMD, if you're not sure about the diagnosis, if the patient gives a history of injection, you know that's the ARMD case, because multiple injections means that his patient has got ARMD. So it's a uveitis case, or ask about systemic history, especially about tuberculosis, especially if you're in the north, it's a very common disease. And also the presence of cardiac disease if you're dealing with vascular retinopathy. And if it's a dystrophy, ask for history of same disease in the family. And if it's a diabetes, ask for coexistent disorders like hypertension, dyslipidemia, and nephropathy, because that may sort of change the picture of the retinopathy. And whenever you don't have a proper diagnosis, VRY was pointing out, people don't expect a proper diagnosis. If you can give suggestive DDs for all, some 2-3 DDs for whatever you're seeing, that itself is enough. Don't keep a set diagnosis and try to fit your diagnosis, all the findings into that diagnosis. So again, all this, how to examine also, just go about examining all the, right from the media, vitreous, disc. So always practice is set patterns so you don't miss things in the, when you're describing also, you have to tell whether the media is clear or not, and why is the media not clear, whether it's a corneal opacity or a lenticular or in the anterior chamber like FM or hyphema, or the vitreous hemorrhage or vitritis, or posterior vitreous detachment, or all the vitreous syneresis, and all those things. Talking about the opticity, you have to talk about the size, shape, color, and margins, and the cup, and the NRR is healthy or not. And if in the retina, you have to look at for any hemorrhages. What type of, when you say hemorrhages, just don't say hemorrhages. You say intraretinal hemorrhages, or flame-shaped hemorrhages, or dot and pot hemorrhages, or if it's a pre-retinal, subialum, or vitreous. So try to say what location hemorrhage. Just don't say hemorrhages. A lot of times I see people saying just hemorrhages are there. You tell me what hemorrhages there are: subretinal, pre-retinal, or intraretinal, dot and blot, or flame-shaped. Mention what is, because each will have its own significance and it will point to a diagnosis. And when you have a look at the macula and what are other findings like drusen, exudates, fluid, so whatever is there, you just try to identify and describe it in a sequential manner, so that if the person who is hearing it, even if his eyes is closed, he should be able to imagine the fundus which you are describing. And foveal reflex, don't say dull. A lot of people don't like it. You say whether it's present or absent, that much is enough. If it is absent, tell why it is the absent. You say edema, hole, or SRF is there, or scar, or blood, whatever is there, or edema like a CME or a DME. So whatever is there, just mention why it is not, why it is absent. So this I told you, but all the presence of the other peripheral retinal lesions you have to tell. So this is the vessels. This is the normal ratio. It's a 2:3 AV ratio. And mention any abnormal, especially in diabetic retinopathy, caliber, venous caliber changes can be important for finder to say whether it's a severe retinopathy or a moderate retinopathy. So, and if it is any sheathing is there, tell them it is a sclerosed vessel or arteriosclerosis, or it's an inflammatory sheathing. Just don't say sheathing. Tell what type of sheathing it is. So it will give again, it will be descriptive of what the pathology is behind that. And if there's any Hollenhaus plaques, still it's intraarterial Hollenhaus plaques. And look for, in adaptive retinopathy, always look for presence of new vessels and IRMA, and always the very common question, how do you differentiate clinically between intraretinal microvascular abnormalities and the new vessels? So it's a very common question if you are present in case of diabetic retinopathy. And in hypertensive retinopathy, look for any AV changes, not skip the first order, and for the second order, just see what are the AV crossing changes and mention it, all the guns, all those findings you have to say. So drawing, you have the Amster-Dubois chart, and when it is like a RD case, you have to keep it inverted to the patient's position and then draw it. The center is the fovea, the disc is just at the first gap there. If it's right eye, it's the right side, left eye is the left side, and the first ring is the equator, second is the end of the retina, and third ring is the end of the pars plana. So most of 90% of the diagnosis should come within the first two rings, and if there's any CD or pars plana cyst, then you can mention in the last rung of the chart. So this is how you keep the chart, and then this is how you examine, and make sure that you are well versed with the how you go about marking the chart. So when you are not very comfortable, skip in when you see, sometimes you can get lesions within the area which you skip. So try to see an overlapping quadrant so that you don't miss lesions in between two exams. So you look up 12 o'clock, ask the patient, look at 12 o'clock, so see the superior quadrant, look at the nose, see the nasal quadrant, but sometimes you may miss something in the supranasal quadrant. So just see in overlapping quadrants, so you don't miss, because one of the my classmates, she was a choroidal melanoma, and it was in a small melanoma, and she missed it because it was in between the supranasal quadrant. She just saw the superior and the nasal and forgot to see the supranasal, and actually she failed the exams also. So you have this is how you go about charting. You have to be well versed in this in your exam, and during the course only you should be able to practice this, and make sure that you have a proper way of depicting all the lesions here. I just show some examples of cases. This is a temporal subtotal retinal detachment. This is how you should describe it. Mention first is whether it's fresh or old, whether it is total or subtotal, and then whether it's what type of regma or tractional or exudative, and the status of the macula, whether it's on or off, and whether it's a phakic or pseudophakic guy, and then any additional findings like the choroidal detachment. So you have how is then it's a fresh total, a subtotal regmonoid retinal detachment with the macula off status in a phakic or pseudophakic. You can see how this one of our PGs has mentioned that in a phakic eye. So this is how you should, when somebody asks for a diagnosis, you should include all these points so that it will tell you in one go, so what type of RD it is. So this is a case of vein occlusion. We tell whether it's fresh or old, is whether a central branch or macular branch retinal vein occlusion. Whether it is, if it's a CRO, you have to mention whether it is ischemic or non-ischemic from the vision, pupil, and other the fundus appearance of hemorrhages are more or less, and the disc edema if it is there, and macular edema if it is there. And mention, you can say that it is the CRVO on a hypertensive patient or a dyslipidemic patient, you can just tell that. And additional findings like new vessels or vitreous hemorrhage. So if it's a macular hole, then you should tell what's the cause of the macular hole, whether it's a full thickness, partial thickness, or pseudo hole. Whether it's a chronic means you'll have a RP degeneration with the elevated SR, because of chronic SRF, because of the elevated edge of the macular hole. And also you can just say it's a half disc diameter or one disc diameter, because you don't have OCT, you cannot say the actual diagnosis, actual diameters, but you can just say the comparison to the disc. So if it's a diabetic retinopathy, you have to tell whether what type of staging from the ETDRS staging, and whether it is CSME is present, because DME is from the OCT, so you have to tell whether CSME is present or not. You have to know how to describe diagnose CSME, whether it's present or not, and any additional changes you have to mention that also. Just I give you some examples from our own hospital where PGs have drawn this. You can see the ARMD with the subretinal hemorrhage. This is how we depict. The central is a fibrotic greenish scar with the red blood, and this is supratemporal RD. This is how they have depicted the macula on RD. You can see the large tear, horseshoe tear. This has been depicted like this with the inferior infranasal lattice. And this is a post-operative gas inside, so you have to put it in green. Any vitreous opacity should be in green, and inferior you have the barraged lattice mark. And this is a preatal hemorrhage in a patient with NV, and preatal hemorrhage in a patient with the PDR which has been already laced. So I'll just stop here and try to present from your memory. Don't, if you're not remembering, you can ask for the chart and describe from that. And I just already mentioned this. So best of luck from whatever exams you're taking. Best of luck.